looking into the actual core of the standards, what to expect from the surgical oncology as well as laboratory pathology oncology part of it. The standards are publicly available on request, but that will be shared later if at all anybody is interested to look into that. So let's start about the first part of future of oncology accreditation. So the video was just to give you an introduction about how the entire oncology standards has been designed. So let's talk about in detail where if you look onto the oncology standards, the clinical excellence actually is been designed to be used by the hospital who are already accredited. So the accreditation can be from any score body. So that's the rule number one that we look for. And that most importantly, why the oncology standards has been designed. So over the last few years of our research, as well as global demand of AACI was increasing, we have been developing AACI clinical excellence standards. If you are aware, we do have stroke and maternity endoscopy other services. What we saw in the market was everybody is doing oncology, but how does the patient knows that which hospital is actually good enough to take care of my problem, right? My disease. As oncology is one of the most end of life, or we can say dreaded, or one of the shocking news that anybody wants to receive, the importance of patient safety automatically pops in. And that is where AACI put efforts and worked almost 1 year and plus globally with different organizations and oncology centers to understand where do we launch and how do we launch this clinical excellence program. The design was basically looking into the centers with different type of care that they provide. So if you see onto the first part, we of course need an accredited hospital. So that's what we call the basic oncology care. So we don't accredit or certify anybody with basic oncology care. So we just move on to the oncology part where advanced oncology centers has been designed. So the first part was to decide upon the services that we offer, right? So hospitals should have these departments. So if you see on the advanced levels, radiotherapy, nuclear medicine, pathology, reconstructive surgeries. Now you may have a hospital more than these. So how do we classify? So both of them get clinical excellence, but then they are divided into different levels that they're advanced oncology centers and someone is comprehensive oncology centers. So we look onto the part of comprehensive oncology centers. We are coming with more advanced services available, including clinical trials, research, brachytherapy, and so on and so on. So this is already given in our standards. The idea behind this is to give the patient understanding that when I go to a hospital with an oncology problem, where do I land up and what type of treatments I usually require and how does that actually works. Let's move on to the future of oncology accreditation, or we call it as the programs, that why we have designed it and where does it actually look onto the leadership and the business part itself. So first point is to develop the excellence centers. So excellence centers are more than what they offer from the accreditation. Of course, hospitals has been getting accredited for different SCOI approved bodies, but how about the oncology as well as a excellence center? So the first part was to do a movement from just about accreditation to excellence standards. The second part is about research and clinical trial exposure. So not every center may not be approved to do research and clinical trials. Now, with oncology being one of the fastest moving speciality with regards to the treatment, testing of treatment, clinical trials, medical advancements, AI, or whatever you call. We want research and clinical trial exposure to be part of the oncology accreditation. One more settings that we have looked around is there are a lot of oncology grants all over the world, which is mostly being used in the centers which are, highly demanded or has been seen. So if you see the US part, mostly the university hospitals, and if you see the Indian part, mostly the bigger organization get a lot of grants. But what about the hospitals who really want to do oncology, and how do they look onto the oncology grants? And this is one of the exclusive opportunity that hospitals get when they move on to the seriousness of giving oncology care. So what we are looking here is how is the hospital's vision about oncology care, or is just about giving some sort of daycare therapy and few oncologists and radiotherapists over here and there. The another advantage or the mechanism that we have looked about is the pharma collaborations. As you know, oncology, pharmacology, with going to a precision medicine, which is the future which we are looking. And how does the pharma companies actually come onto this path? So establishing strong partnership with pharmaceutical companies is one way to showcase that our hospital is serious about oncology, and we actually look into beyond just about giving drugs, but actually collaborating with the hospitals, because pharma company of course require clinical trials to be done, and your patients come over there. So this is another collaboration that opens up. What about the competitive advantage? We all know that our hospital is accredited, and accreditation is common. People do look on accreditation, but what about the clinical excellence where you demand and you can showcase that your oncology services is better than anybody else? As we look into the international patient care network, global reach is an important thing. How about the visibility and credibility that you promote when you reach the clinical excellence that our onco department or center or hospital is doing these levels? And we have been checked and verified every year. And that's AACI's USP. We come every year to see what is going on the ground. And that is where we actually make sure that the patient care network is going beyond. So last point to reach into, we are looking over here as beyond doctor's concept. Of course, oncology is driven by the doctor's experience, name, the protocols he uses. But when we look into the hospital sites, it's not just the doctor as well as the drug. It actually has to be an entire oncology ecosystem, which needs to function as per the requirement. So if you look, the onco nurses, which has been a specialty for a long period of time, the researchers who work with oncology, the pharmaco people who works on the ground in oncology wards as well in daycare settings, it's the entire ecosystem that needs to be checked. So each department adding on its own values. So laboratory, pathology, genetics. So it's not just the doctor of the cancer treatment is required. It's all about the holistic approach. So this was the idea behind getting into a future of oncology accreditation as well as the certification process from AACI. I will right now will hand over the requirements where we work with Dr. Nidin as our oncology specialist. So Dr. Nidin, please take over from this end.
Dr. Nidhin, you're on mute.
Sorry about that. Hi, all. Thank you, Dheeraj, for the nice introduction. I'm Dr. Nidhin. I'm a radiation oncologist by training. I've been in this domain for the say last 13, 14 years. Uh, all my life, I've been a clinical oncologist, and in due course, I moved into quality. I was with the Cancer Care Commission, Oxford, for quite some time, and then now with the ASA. So, coming to the ASA clinical excellence, Dheeraj has put a very nice introduction on how ASA looking at the introduction in terms of patient-focused care. We always talk about patient-focused care. How is it different? Actually, we all have, say, take the example of a tumor board. We all have tumor boards at our institutions, right? So how is the ASA proposal of an NBT any different from a normal tumor board? I would say that in a normal tumor board, we are going by a case approach. case-centric approach. Whereas in an MDT, it is a multidisciplinary team which consists of not just the oncologist. We'll have the radiation oncologist, medical oncologist, surgical oncologist, pathologist, radiologist, in any other tumor board as well. But in a multidisciplinary team, as designed by AACA standards, we're looking for people from other discipline also. There would be a nurse coordinator, there would be a clinical pharmacologist, there would be other people who are involved in the patient care. Could be from palliative care, could be from social and rehabilitation services. Anybody who is involved in the patient care is a part of the MDT. So it's broader, it's more collaborative, it will bring in more inputs, and it will definitely improve the quality of the care delivered to the patient. This means we'll have a holistic approach where we'll be looking at the patient as a whole rather than as a case. We won't be just treating a CA breast or a CA endometrium or a CA stomach. We'll be looking at the patient, the whole aspects of the patient, and we'll be delivering the care according to the standards. This is what the ASA standards are trying to look into. So coming to the holistic approach, we are, like I said, we are not just looking into the care plan as such. Actually, we are also focused, also looking at how you're doing the prevention packages. Actually, how are you doing regular screening packages? Any screening modalities you particularly uh, encourage? Any screening programs? What are the substance abuse programs you are doing regularly? And are you doing any converse surveyship means? These are the things we are looking at. Next slide, please, Rohina. Thank you. And next slide, please. Okay. So when we comes to radiation oncology, there is radiation oncology, surgical oncology, medical oncology. When you take a medical oncology department, uh, most of the centers in India are doing a decent job. So how is ASA going to bring any change into that? So what are the things we look into it? So we are basically looking at a zero harm chemotherapy policy where we'll be looking at how the medicines are prescribed, how the medicines are delivered from the pharmacy to the oncology unit. Looking at the preparation, is the medicines are prepared in a specific chemotherapy unit under the adequate international standard protocol conditions, and is it administered properly? Are we looking at the misses? Are we looking at the near misses? Are we looking at the clinical audits of how many misses or near misses have been noted in the last month or say last 2 3 months? Are we looking into the causes of that? Are we looking at adequate measures to correct it? So are we doing a regular audit of the misses, near misses, and all? Then one point I would like to stress is that most of the centers in India are doing a decent job with this. But again, when it comes to the medicine disposal, the cytotoxic drug disposal, I have seen uh, flaws in even in some of the major centers actually. So we are looking at whether you have a streamlined hospital institution policy of handling the cytotoxics, not just preparing, but disposing the cytotoxic as well. Also, ASA will be looking into the supportive services where pain and palliative care is of paramount importance. Pain and palliative care, see, like we said earlier, not just the treatment, the patient would be going through pain mostly. Even if not, are we doing a screening for the pain? Right when the patient presents, are we enrolling them into a pain and palliative care program? Are we doing a screening for the pain? Are we doing any audits of the pain protocols, pain assessment protocols? Then, do we have adequate facility to refer the patient to a psycho-oncology department in case the patient requires? Also, the patient might need rehabilitation. A GBM patient may not be able to go back to his or her daily routine life after the treatment. He or she would need some kind of rehabilitative help. So, do we have enough facilities or enough facilities to refer to? At least we should have an MOU in place to facilitate that. Also, the ASA standards require a social service counseling if the patient demands. Thank you. Next slide, please. Like I mentioned earlier, when we go into the radiation chemotherapy units, we'll be looking at the doses. In the radiation therapy department, we'll be looking at the doses delivered per fraction. Is there a major or minor deviation from the delivered dose or intended dose? Do we have a protocol in place to report the deviated dose? Or if there is a dose inaccuracy, if there is a major inaccuracy, do we have a protocol in place to report it to the chief oncologist or even to the national regulatory agency if required? Also, when patients are admitted, some of them would be requiring an end of life care. So, does the hospital or institution has an end of life care policy in place? So, do we have an do not resuscitate, do not intubate policy? So, how well we are documenting it? Are we doing a clinical audit, a regular clinical audits? I would say regular clinical audits of these protocols in place. Also, we would need to give a handout of the patient's rights, not just the patient's rights, but the patient's rights particular to end of life care. Are we having any policy in place to take the advance directives of the patients? All these are looking up at. We are also focused on research and education. We understand clinical trials are paramount important for the specialty to move forward. So we'll be looking at how well the research protocols are done in the department. Most importantly, the privacy of patient data is securely kept or not. So these are the things we would look into. I'll happily hand over to my colleague and senior Dr. Baby to talk about the surgical oncology part. Thank you.
Good evening. So when the standards were being designed in surgical oncology, clinical excellence in surgical oncology was aimed to look at three focus areas. First is the focus on basic improvement in surgical and anesthesia care, focus on comprehensive and inclusive perioperative surgical services, and focus on post-operative care. As we all know, the surgical oncology has three-pronged, utility in the overall oncology care. They help us in diagnostic by taking biopsies. They help us in curative by taking out the tumors. They help us in palliative care by debulking or removing, decreasing the tumor bulk. So, surgical oncology forms a very big part of the whole ecosystem of the oncological care. So next slide, please. So focusing on the basic structure of surgical and anesthesia care being provided at the oncology center, we look at excellence in the OT services. In the OT services, we look at how the surgical services per se have been rolled out. We look at the surgical services, whether it is the surgical services are being provided by properly credentialed and privileged individuals, whether the OT services are akin to the scope of services the hospital is providing, whether the OT services are being complemented by the laboratory and pathology services, about which Dr. Deepti will be talking to you in a large detail. Then we also look at anesthesia services, whether it complements the surgical services or not, the way it is rolled out, whether the individuals are qualified enough or not, whether we are taking care of pre-operative, perioperative, and post-operative anesthesia care, whether we have defined the pre-anesthesia services according to the available scoring systems, whether we are monitoring the patients intraoperatively and what kind of monitoring we are doing. And in the anesthesia services, we also look at the immediate post-anesthesia care in terms of the post-anesthesia scoring and how safely we are shifting the patients from either to the wards or the ICUs. And we also, a big part of the entire surgical and anesthesia standards is the quality of supportive services in the theater, the quality of air conditioning of the theaters, the quality of the housekeeping services within the theater, the quality of infection control. We also very deeply look into how the sterilization services have been rolled out and how they have been integrated into the entire gamut of perioperative care, especially in the context of the oncology services. Next slide, please. So comprehensive and inclusive perioperative services includes all the modalities of service which may be needed surgically, like reconstructive surgery, aesthetic surgery, functional restoration procedures, Is it being complemented with the rehabilitative and reconstructive services or not? Do we have facilities available to process the biopsies which are being generated from the theater? Are we able to provide the surgical reports as quickly as possible? Are we integrating those services with my complementing services? And we also look at compliance of these requirements from a quality perspective. Are we analyzing our theater goings on? Are we analyzing how good at reconstruction we are? So we look at various parameters. There are a lot of matrices which have been designed to look at those services. Next slide, please. So in the most important part for us in the whole surgical services is the post-operative care. Do they have timely access to the rehabilitative services? Are they being rehabilitated in the hospital as well as back into the community post their surgeries? And the center, the cancer centers shall continuously screen and treat the patients for pain. The families should be involved, and the way we are educating the patient and the families, because the pain management goes beyond the hospital precincts. It goes into the house, it goes into the community of the patient. So are we focusing on alleviating the pain from all the angles, psychological angles, the pharmacological and the other interventional angles as well? Have we integrated the palliative care and when to initiate the palliation, not only surgically, but as well as Dheeraj and Nidin have already described, we look at very holistic, comprehensive approach to the management of not the patient, but the entire ecosystem around the patient. And we also focus at the information and education to the regular, updating our staff on the pain management, teaching them ethics, teaching them compassion, teaching them putting themselves into the shoes of the patient and thinking like a patient, what from their perspective, and all this have been put into our standards. Next slide, please. Thank you. That's all from my side. I hand it over to Dr. Madhu now.
Thank you, Dr. Bedi. I hope I'm visible and audible. I'm Dr. Deepthi Madhu. I'm a microbiologist, MD microbiologist, a certified professional in healthcare quality and in infection control. I have been a clinical lead surveyor with ASA close to 2 years, and I'll be walking you through the laboratory pathology and the blood transfusion services, more general with accreditation in general, ASA accreditation, and in specific to oncology. Those points which are very specific to oncology, we will be emphasizing on. So when it comes to laboratory and pathology, any accreditation standards require us a few major things like laboratory safety, critical alert information, turnaround times. So all these stand true and valid even when we come for an oncology excellence certification. But in addition, like all my previous speakers, my colleagues have said, the settings of oncology require a timely addressal of issues, a little more emphasis on the matters, because we are literally battling with, it's a life and death situation. So there need to be the set of services, laboratory services, which are required for oncology service provision. It may not always be feasible to have it in-house. That is completely understandable, completely acceptable. But where your laboratory falls short, you are required to have an MOU, an arrangement with an external laboratory which is capable of providing that services in your unit, so that clinical service provision is not delayed. So there should be adequate laboratory services. Where in-house is not available, there should be external provision with an MOU, with a valid MOU. And any outsourced services shall be integrated into the healthcare organization. Critical laboratory information. When it comes to an oncology setting, the cutoffs of the critical information also will be slightly different. So it needs to be defined accordingly. turnaround time shall be reasonable. It cannot be, this is our turnaround time, and that is, it should be in consensus or in accordance with international standards, especially since, when we are dealing with oncology patients, we are in a race against time. And the laboratory shall make provision for proper receipt and reporting of specimens, which is true for any accreditation standard. Shall we move to the next slide? And when we come to the pathology services, the supervision of a qualified pathologist, a credentialed and privileged pathologist, is an absolute non-negotiable. The level of service and the duration of service, etc., can be according to the requirement of the institution. But where pathology services are provided in-house, there should be a qualified, credentialed, and privileged pathologist. And it should have information sufficient. It is not just whether a report is available, the quality of the report and the content should be clearly defined, that it includes all information sufficient to allow appropriate grading and staging of neoplasms, because we are talking about oncology clinical excellence here. So just a histopathology, not just a histopathology, it should be aiding in the grading and staging of neoplasms according to standard classification schemes. Those particular terminologies, the relevant information pertaining to each cancer screening should be available. Then reporting time for intraoperative frozen sections. So frozen sections is again an optional service in most of the settings. But if you are providing frozen sections, intraoperative frozen sections in your unit, just providing is not sufficient. It is something that is done within the time of the operation. So the turnaround time. This is one situation where the accreditation certification standard has come out and said the turnaround time should be 45 minutes, not exceeding 45 minutes, but it should be within. The timing is calculated from the specimen arrival in pathology to the time the report is returns to the report is available at the OR. So this is one situation in the entire accreditation forum. The turnaround time has been explicitly stated. So wherever we are defining TAT, there should be it goes without saying that there should be a methodology or a provision for capturing and monitoring the TAT also. That is written between the lines for us to understand and interpret. The time for other histopathology tests shall not exceed 7 days. Like I said, when we are dealing with oncology, every day, every hour matters. It's a race against time. And here again, this is very specific to the oncology certification. It shall not exceed 7 days. And immunohistochemistry, again, this is required for the initiation of chemotherapy or neoadjuvant chemotherapy in many of the cases. So the immunohistochemistry TAT also shall not exceed 7 days. Where the TAT is explicitly stated, it is clearly understood, and it should be read between the lines that there shall be a methodology for monitoring adherence to TAT. The laboratory shall hold oncology-focused learning events for quality improvement. This can include clinicians, or it can be within the laboratory, including all the personnel that are involved in the provision of reports. So oncology-focused learning events for quality. And inadequate specimens. This is one setting where inadequate specimens cannot be entertained. There should be a clear defining of refusal of, or what are the criteria for rejection or refusal of specimens, and it should be clearly adhered to. Then there should be safe handling. Now, this is something very unique. This is something that, laboratory safety and radiology safety are very well understood and accepted. But in an oncology setting, there may arise situations where laboratory safety and radiation safety need to meet together in the provision of services for ensuring the safety of all those who are involved in the handling of the specimen. So where required, if there is a tissue or a specimen that is generated which has radioactive potential, that is, if it's from a patient who has been recently administered a radioactive agent, then the radiation safety officer should also come into the play in the handling of the specimen. So this is something that is exquisitely reserved to or designed for oncology setting, and this is what makes the certification program a clinical excellence program, because it's not just about patients or doctors, it's about the safety, the whole rounded safety of the service provision. Then surgical pathology materials shall be retained as required. This is according to the law of the land, so that goes without saying. Now we come to the blood transfusion services. The requirements of blood transfusion services are in tandem with the blood transfusion services of The law of the land also requires, the CITESCO also requires in India a certain set of things to be monitored and done. The same things are valid here also, but with emphasis to a few more aspects like transfusion reactions. Transfusion reactions in an oncology setting needs to be monitored, not just for the sake of monitoring. Here, the root cause analysis and the corrective and preventive action need to be meticulous and meticulously documented also, because we cannot afford a recurrence of a preventive corrective action. So where something can be prevented, we need to prevent it through a proper root cause analysis. Another thing is screening for transmissible infections in the case of donors, which is again according to the law of the land, but we need to be meticulous, and the tracing of the donor, the tracing of the products used, everything should be in place, because we are talking about patients who are again battling with against time. It's a race against time, and they're battling with death. So in blood transfusions, they need to be considered as, they need to be monitored just like intravenous administrations. And healthcare organizations shall have a defined blood transfusion process. And the personals who are involved, including the nurses, they should be credentialed and privileged for providing the services. And blood usage policy, it's there is blood transfusion policy and there is blood usage policy. And the basic dictum is wherever blood transfusion can be avoided, we should avoid it. It is even more so in the case of oncology patients, because there are a lot of neutropenic situations. We deal with bone marrow transplant, everything is in place. So the policy shall describe the appropriate use of alternatives to transfusion wherever possible. It's not just like, the policy should not be restricting to how to transfuse and when to transfuse and how to go about it and how to document it. The policy shall also describe the appropriate use of alternatives to transfusion where possible. So these are the general aspects of blood supply and management and blood transfusion with emphasis to oncology. So that concludes the laboratory pathology and the blood transfusion aspects pertaining to accreditation in general, AACI in specific, and very specifically to the Oncology Excellence Program. Thank you so much.
So thank you, everyone. Thank you, Dr. Deepti, Dr. Bedi, and Dr. Nidin for being here and giving the insights on how the oncology accreditation works. So we have a couple of questions, which, of course, we need to discuss right now. So first one is regarding a conduct of clinical audits in oncology. So if you know the ASA methodology as such, we are not talking about the ASA accreditation standards here, because our methodology of accreditation and certification is same. The hospital can define their clinical audits as per their requirements of what they're getting. So basically, it is given to the hospital to decide what are the frequency assets. So we don't go into that levels, that frequency to be done. But when you look at the audits, when we look at around the entire process, of course, we see the yearly data, right? So internal surveys happen yearly once. So automatically, you will be doing a clinical audit once. Now, which clinical audit specifically you need to go detail, it's up to the end user. That is what we call the organization to define. So the direct answer will be at least once a year you have your data to be built up and you work on it. And that is what the first question goes like. This is another question. I will have Dr. Bedi to take that one. So the question is how the implementation of end-of-life care is to be verified. What documentation hospital is expected to maintain? Dr. Bedi, please.
Like any other accreditations body or any other accreditation standard, the baseline will be, we'll be looking at your policy. How are you dealing with end-of-life care, and what is the vision of the institution with regards to end-of-life care? Once we have had a look at your policy, we'll look at the implementation part of the policy by interviewing the staff and by judging their, by looking at their awareness and their participation, how participative it is. Then we look at documentation being maintained when end-of-life care is being delivered. We'll look at thoroughly, we'll go into very detail into every kind of documentation which we maintain, which pertains to end-of-life care, and it has to match and has to be in consonance with our own policy, which we have designed according to the needs of our community and our patients. Thank you. I think I've hoped, I hope I have been able to answer.
There's another question, or I don't know if it is a query. Dr. Nidhi, maybe you can answer, or anybody from the team. Are there any recent advancements in the bloodless medicine that hospitals should adopt? Uh, Dr. Nidhin, if you want to go ahead. Bloodless medicine.
Bloodless medicine.
Yeah.
I didn't get quite the question. I didn't quite get the question actually. I didn't understand what they're looking at actually.
That
Bloodless
is what they
medicine
are
in the
asking.
sense.
Are there any recent advancements in the bloodless medicine that hospitals should adopt?
Alternatives to blood transfusion is what the question is, I believe. So there are no recent advances. Correct me if I'm wrong, Dr. Nitin and Dr. Bedi. We do not have any advances in that particular aspect. But for oncology patients, for generally for any patient and for oncology patients in specific, we keep blood transfusion as a last option because it does come with its own set of risks and problems and things that might require resolution. So, and oncology patients by themselves, as part of the treatment itself, there are enough variables into the equation. So if at all the patient goes into adverse reaction, for us to come to the conclusion that it is this blood transfusion that is the root cause, it'll take us time. So we preserve blood transfusion as a last possible alternative, but the medical alternatives, there have been no recent advances. It is the same as always, according to the requirement of the patient. Yes.
Hey, thanks, Deepthi. Actually, I would like to add a comment to that. As she rightly pointed out, actually, blood transfusion is the main part of the treatment. Though there are some tablets available to correct thrombocytopenia, to correct the total count, still blood transfusion holds the mainstay of the treatment. Thank you.
Great. I hope that has been cleared from your end. There's another question is blood bank agreement from other like outsource should be the accreditation one. So as I said, this is a clinical excellence program. Now, if you say that I don't have a service and I outsource a service, then it goes back to our accreditation standards. And if you see accreditation standards of ASA 2.6 says about outsourced services. So then it goes back to the link. So any non-compliance originating from our accreditation standard has to be dealt in the same way. So we don't develop again another accreditation standard. So clinical excellence is already backed by a 130 pages standard of hospital accreditation. So whatever is written over there has to be in place. If not, there's a non-compliance from that section. So suppose your outsourced services linked to oncology is not meeting the requirements of outsourced standards, as well as the turnaround time, as Dr. Deepthi said. So somebody doesn't have a laboratory pathology, but the standard specifically says the turnaround time. So then it becomes a non-compliance. Suppose you have a frozen sample to be sent 2 hours from your operations theater. It's impossible that you get the things done, right? So a patient won't stay in the surgery for 2 hours to get a report in. And then again, if the outsourced services has been incorporated over here, then we see the documentation and entire workflow of that outsourced services, whether it is meeting the patient requirement. So the question here is, we don't write again and again the same thing what we have written in 130 pages of accreditation. This is very specific to clinical excellence that we consider as the hospital is already abiding. If not, they need to fix it. I hope I'm clear.
Dheeraj, may I add a few comments
Please
on
go ahead.
that? It is not absolutely required that the outsourced blood bank that you're getting into an MOU, that it be accredited. There are 2 reasons for this. One, or for a blood bank to get its license, for it to be functional, it has to go through the CIDSCO licensing process. And most of the licensing processes make sure that the QA process is meticulous. Everything, including the transfusion reaction and the turnaround time, is monitored by CIDSCO. So things will have a baseline. The baseline requirements would automatically be met. And the second reason why we say that is, see, whenever you enter into a service, you will draft a MOU. So make sure that whether it is an MOU with the accredited blood bank or with the non-accredited blood bank, make sure that your MOU cites explicitly the TAT that you would monitor if the blood bank was yours. So TAT, emergency TAT, transfusion reactions. So all the quality parameters that you would want them to give you access to, or you would want them to monitor, so that you can show your during your clinical excellence accreditation or certification process, all those cite specifically in the MOU, so that they are also clear about what the requirement is, you're clear about what that your requirement is met, and you have a documentation to show for it.
Absolutely great. We have one more question. I think it's again related to Dr. Deepti. So, for outsourced laboratory tests like ISCs and molecular tests, does the 7-day TAT remain?
The 7-day TAT remains. It is you can say set in stone, because even if it's an outsourced laboratory, it is up to us to make sure that we have a outsourced laboratory chosen, taking into consideration many things. It's not just for the service that is being provided, it is also taking into consideration the TAT. For example, if you have two pathology services lined up, as in two labs which are willing to provide the services to you, both of them have, they would have the services in their panel. One is offering to give you the reports in exactly 7 days, and another one is saying we will give you reports every Thursday and Saturday. So if they say every Thursday and Saturday, so for a patient whose surgery was done on, say, Saturday evening, the 7-day TAT may not be met. So it is for us to choose. And you can say that this is the reason why we chose Lab A, is because their policy of TAT is in adherence with our requirement. That can be a criteria for choosing your outsourced laboratory as well.
Wonderful. As we say always, we see the biggest gap in implementation of these services is about how do you manage your outsourced services along with your service line that you are taking care of the patient. So patient safety and quality automatically pops up when you have the entire pathway of outsourced services matching, as Dr. Deepti said, you have your own setup at your hospital. So it cannot be a reason that I don't, it's just an outsourced lab. We cannot have that. That's the way that your contract has been made. And that's why the ASA accreditation standards have entire definition of outsourced services. Great. Any more question and answers? We will be happy to have it. We have 10 more minutes with the timelines. We tried our level best to keep this session short and good for everyone to ask questions. So we'll wait for any more questions if at all anybody has. If no questions, then I will give some upcoming opportunities for you guys just to understand. So we have been running ASA internal survey course for the last 1 year, trained more than 200 people, and now we are coming on site as well as with Kaho and Amrita Hospital. If you have not seen the news of ASI, Amrita Hospital is the first oncology CEC accredited hospital in the world, and we take proud that Indian hospital was the first one to jump into these service lines, and exceptional facility to understand the oncology standards and how they have imbibed the standards of accreditation as well as certification in the least period of time. So I believe India holds a huge exponential potential for oncology services worldwide, a huge number of patients, medical tourism. So any hospital looking for getting these services, not just for the purpose of putting a badge on your hospital, we actually want the patient safety services to be improved. And I say from my experience of talking to other CEOs, visiting other different countries, oncology care with the speed and precision what India is offering and the cost, I think we can beat the other countries very easily. So that's the reason that ASA has invested time and resources to develop these standards. So that's all from our end. If you can follow us on LinkedIn, we are always available with your requirements. Those who have attended this whole thing will be getting the certificate of participation from the ASA as such. Thank you, everyone, and have a good night. Thank you, everyone.